So hello friends. So today I'll be talking on this sepsis protocol. So if you remember, we had presented the general protocol on COVID management to all the district hospitals. So I'm presenting this sepsis protocol for all the district hospitals to be familiar with how do we manage COVIDs who present with sepsis bar septic shock. So this is the protocol we have circulated to all the district hospitals. So this is an algorithmic protocol which take you step by step as to how we uh, address a patient coming with COVID with sepsis or septic shock. So the first question in all of our mind is how do we recognize this sepsis? The critical aspect of COVID presenting with sepsis is for a district hospital physician to identify that this is sepsis. So what is sepsis? Sepsis is the life-threatening organ dysfunction due to dysregulated host response to a COVID virus. So what it means is, along with respiratory failure or cough or respiratory symptoms he present, there is a concomitant presence of other organ dysfunction, be it acute kidney injury, if creatinine is high, or if he has hypotension, or if he presents with obtundation, or if he has low platelets. So all that constitutes sepsis because he has other organ dysfunction which is complicating his clinical course. So the quintessential aspect would be the first step is to identify. First step is to identify that this patient is in sepsis. As soon as you identify that this patient who is COVID positive is in this sepsis, then we are bound to follow something called 1 hour bundle. And whatever I am articulating is based on surviving sepsis guidelines, which is followed worldwide. So what does 1 hour bundle say? That the patient comes with hypotension or features of sepsis, the first step is we have to administer fluid resuscitation. So this is something I want to emphasize to all the district hospitals. When we say fluid resuscitation, it is not maintenance fluids. So what typically I see is, when I say fluid resuscitation, the answer sometimes I get is we are giving fluids at 120 ml per hour or 150. That is not what we mean as fluid resuscitation. Fluid resuscitation is giving a large volume in a short period of time as a bolus and seeing how the hemodynamic response has been to that fluid that is administered. And the fluid that we administer is a large volume, and that volume is defined as 30 ml per kg. So if it is a 60 kg gentleman, we are bound to give around a minimum of 1.5 to 1.8 liters in 1 hour time, in a short period of time. Or if you want to give 500 ml bolus, you are meant to give 500 ml bolus in a short period of time, 20 to 30 minutes, within 1 to 1.5 hours. So that's what it means. And if blood pressure does not improve with this fluid resuscitation, so you would continue fluid resuscitation, but don't wait. You may have to start vasopressors. Noradrenaline is the first vasopressor of choice. So we are expected to start vasopressor if there is no response to that initial fluid resuscitation, and then reassess whether there is room to give more fluid. So this is what we mean by whether fluid challenge has been given or fluid resuscitation has been given. And the third most important aspect that the doctors of district hospitals need to see is measure lactate. We understand that many of the district hospitals do not have ABG, so we will make recommendation to the chief nodal officer to make arterial blood gas or ABG machine available where we could measure lactate, because the measurement of lactate becomes terribly important in management of sepsis. The reason is we give this fluid resuscitation, so we monitor whether lactate is coming down, because if lactate is coming down, then the patient is responding well and there is a response to the fluid that you are administering. And lactate generally should be less than 2, or it should not be there. If it is more than 2, then he is in sepsis, and you would monitor. You would give this 30 ml per kg body weight as a fluid bolus, and after an hour you would repeat a lactate to see if lactate is come down. If there is a 20% reduction in lactate, it is an indication that he is responding to the fluid resuscitation that you are administering. And the fourth most important thing is to send 2 sets of blood culture. Albeit it is COVID positive, nothing prevents him from having secondary infection because he is in sepsis. In sepsis, it is mandatory to send 2 sets of blood cultures, following which appropriate antibiotics has to be initiated, which could be community acquired or whatever is determined by the local policy and at the discretion of physicians. So you would administer antibiotics. So as per the globally accepted or global standards surviving sepsis guidelines, these elements, these five elements are quintessential in management of sepsis and has to be done in a time bound way. So the key element is that it has to be administered ASAP, as soon as possible, and desirably within 1 hour. So that should be always in the forefront in any physician's mind when they are dealing with COVID who presents with sepsis. Okay, now the question is identification of patient, COVID patient with sepsis, I said is extremely important. How do we identify? So if a COVID patient comes with confusion or drowsiness, then it means there is, in addition to his respiratory symptoms, there is an organ dysfunction, which is a brain dysfunction, which indicates to us that he is in sepsis. Or patient has tachycardia, more than heart rate, more than 110, 120, and he has hypotension, so where his mean arterial pressure is less than 65, or you have a systolic blood pressure which is lower than 100, or diastolic less than 70, or map is just diastolic blood pressure uh, plus systolic minus diastolic divided by 3. So you calculate that and you determine whether map is less than 65. So when there is a hypotension, it means that patient is in sepsis. Or if patient has hypoxemia, which is calculated by PaO2 FiO2 less than 300, then you know that he is hypoxemic, needing oxygen. That is an organ dysfunction. Or you do the initial blood test and you see he has a jaundice, or his AST ALT is elevated, then that also qualifies that. Or patients with COVID, there are reports of them coming with high bilirubin. So that is an indication that patient is in sepsis. Or patient comes with COVID and then you do a blood gas, some of the blood gas reports may show creatinine, or you may get a history that is not made urine from morning. So he has acute kidney injury where creat is elevated, then you know that patient is in sepsis. Or if you have a patient with COVID positive with low platelets, less than 150,000, 1,50,000 is sepsis. Or COVID patient where coagulopathy has set in. So these are the key organ dysfunction that one would look for to ascertain and determine that patient is in sepsis or septic shock. We call it as a septic shock when there is a hypotension, or when there is a worsening lactate of more than 4, then you would know that there is tissue hypoperfusion and patient is in shock. So now in 1 hour, we understand you would have given 30 ml per kg. After that, how do we follow? So then again, you will see whether his MAP is increased to more than 65 millimeter mercury. So if MAP is increased to more than 65, check lactate again to see if that initial lactate what is measured has come down. And after you're given the fluid resuscitation, it's always good to get a screening echo for any patient with life-threatening organ dysfunction, which could be any of those organs that I have illustrated. We need to upfront, desirably, it is recommended that we do a echo to assess the LV function. Why do we assess LV function? Because COVID per se can cause myocardial dysfunction, and to continue our efforts in fluid resuscitation, we need to know how the cardiac status is, because if he has a severe LV dysfunction, obviously will be tempered in not giving too much of fluid resuscitation. So upfront assessing the LV function will give us an indicator whether we could aggressively continue with the fluid resuscitative measures that we have in mind. So once you do that, you again check the lactate. If lactate is more than 2 millimoles, if lactates is more than 2 millimoles even after having given 30 ml per kg, and you know that your LV function is good, then again you would continue. You would continue the fluid bolus, and this fluid bolus you could decide. So initially you are given 30 ml per kg. If LV is very good and lactate is more than 2, you can repeat this fluid allocats of 30 ml per kg, or maybe you can ascertain, but definitely some bolus has to be given in a short period of time. It could be 1 liter, even you can agree upon giving 20 ml per kg, but some fluid resuscitation has to continue to make sure that your lactate start coming down. And if lactate, after you are given that initial 30 ml per kg in 1 hour and lactate has come down, it means that patient has responded well to your fluid resuscitation. And if his blood pressure is stabilized, then you can't leave him there. You have to monitor, closely monitor how his organ dysfunction. If he's drowsy, has he gotten better from drowsiness? If he's hypotensive, has blood pressure resumed back to normal? Or if he's AKI, if he starts making urine, then you know he's had a good response to that initial fluid bolus that you have given. So this is in a situation where blood pressure has improved, but lactate is something you're monitoring. Suppose after that initial resuscitation, after the initial resuscitation, if your MAP is less than or equal to 60, which means after initial resuscitation also your blood pressure is still low, then again you would check lactate, check LV function, and at this point of time you have to assess your capillary refill. So you have to look at capillary refill. If it is less than 2 seconds capillary refill, then it means there is a good microcirculation and your fluid optimization is better. But if your capillary refill is more than 4 seconds, it means there is a defective microcirculation. So your microcirculation is affected, and then you may have to continue fluid resuscitation. So then the question remains, so which means even here there is a room for giving fluid resuscitation because your microcirculation is still not optimized at this stage. So you wouldn't wait if blood pressure, see here blood pressure is low, you have given fluid resuscitation. So our understanding is you would have started vasopressors, because you concurrently, if blood pressure has not come up with your initial fluid resuscitation, and the previous algorithm you saw, we would initiate vasopressors. But here, after noradrenaline, blood pressure has still not come up, you would consider adding a second vasopressor if blood pressure is very low. The desired vasopressor is vasopressin along with noradrenaline, or you may have to increase the noradrenaline dose. This is in the setting where LV function is normal. Okay. And when patient comes to this stage where you are given two um, follow-ups of fluid boluses as per the algorithm, and you are mandated to start vasopressors to maintain blood pressure, it is suggested or recommended and desirable to have an arterial line in place to closely real-time monitor the blood pressure, because non-invasive blood pressure may be little inaccurate and it does not show real-time representation of changes in blood pressure. So in our unit, all hypotensive patients who are on vasopressors mandatorily have norepinephrine, and this is what we would advocate. I understand some of the district hospitals have difficulty in getting art line, but this is a time where you could equip your all ICUs and gear it up to have this art line facility available. Okay. So once the lactate is more than 65 and the lactate clearance is present, so then it means that he has responded well. So you would assess his fluid volume responsiveness and continue fluid resuscitation if needs be. But you would monitor the organ dysfunction. So in the group where MAP is less than 65, you are given second follow-up of fluid resuscitation, started on vasopressor, put an art line, noradrenaline, you would repeat a lactate after 2 hours. If there is more than 20% clearance of lactate, then it means that he is fluid responsiveness and there may be more room for fluid allocation. So again there you will ascertain whether MAP is continuing to be low. So MAP was less than 65, you are given 30 ml per kg fluid bolus, then you have checked his capillary refill, his capillary refill was more than 4 seconds, so you're given a second run of 30 ml per kg of fluid boluses, started vasopressor, noradrenaline and maybe added vasopressin, you put an art line, and then you see your MAP is still less than 60 to 65, then you have to do advanced fluid responsiveness maneuvers to determine whether there is more, because already you are given 1.5 liter, 1.5 liter. By now I would have thought you would have given 3 to 4 liters for a 60 kg individual. So after this we have to be very careful whether we can continue to give fluid resuscitation. So this is where we need to see whether there is room, whether patient can tolerate more fluid resuscitation. Here we do something called advanced dynamic hemodynamic indices to determine whether there is still room for fluid. So there I would suggest the simple test to do is passive leg raising test. You don't need a great technology for this, or if you have an ultrasound echo machine, the simplest thing is to just put a probe on the IVC and look at the IVC diameter. If it is less than 1 centimeter squared, then you know that patient is hypovolemic. If it is more than 2, These are all very crude ways. If it is more than 2, then you know he is possibly euvolemic. And the way we do in our unit is we do IVC collapsibility index, which is maximum IVC diameter minus minimum IVC diameter divided by maximum. If it is more than 40% in spontaneously breathing, then you know the patient is fluid responsive. So I will talk about it in the, I think the formulas and the values are given at the end of the algorithm, so you can go through the algorithm. So the simple test I would advise for all the district hospitals is a simple delta pulse pressure change. So this is something every district hospital without absolutely no facility also can do. So your patient with sepsis where you have done all this, so you would measure a blood pressure in this position where patient is propped up, and then you check a pulse pressure, which is systolic blood pressure minus diastolic blood pressure. Then what you do is you put his head down and put his legs up, and once you put his head down and legs up, keep him in that position for 60 to 90 seconds. It's very important that you don't put his head down, legs up, and immediately check blood pressure. You need to put his head down, legs up, wait for 60 to 90 seconds, which is 1 minute to 1.5 minutes, and then again check his blood pressure. And then you look at the pulse pressure, which is systolic blood pressure minus diastolic. So here if you get say pulse pressure of say 50, here you get a pulse pressure of 60, then you look at the percentage change, the 10 raise, is that equal to 15%? If the change is more than 15%, then you know he's still fluid responsive, and you can continue to give fluid resuscitation, not at 30 ml per kg, maybe a lesser dose, maybe you give a 500 ml allocates, or you can give 1 liter allocates, or 500 to 1 liter allocate is what you can continue. Because why we say 500 ml to 1 liter at this stage is because he's already got 3 to 4 liters before you started his vasopressors and all that. You would have given already 3 liters. So we assume right now you have to be little more judicious. So you, if delta pp is more than 15%, you can continue to give another 500 ml and see. Suppose after you have given 30 ml per kg and run up of a second allocate of 30 ml per kg vasopressors, your MAP has improved and your lactate has come down. There is more than 20% clearance of lactate. Then you don't have to worry. You have to just closely monitor and reassess and look for any organ dysfunction. So I would urge all the district hospitals, any patient with sepsis, when we say sepsis is not only hypotension, it is sepsis is organ dysfunction, life threatening organ dysfunction, and that organ dysfunction could be cerebral, which can be obtundation, or AKI, or liver dysfunction manifested with jaundice, or hypotension, or tachycardia, low platelets, and coagulopathy. Any of these can be organ dysfunction. So now the second question which would be running in everyone's mind is, what if patient is intubated and mechanical ventilated? So if patient is, suppose patient is come gasping. I mean, when we do rounds, tele rounds for these district hospitals, we've had questions coming that patient came gasping and they intubate the patient and he's hypotensive. So there also we need to ascertain, how do we ascertain fluid responsiveness? So these are all different indices that we have. So if you have a monitor, Philips monitor, uh, the later versions, so they all have something called pulse pressure variation. So you can talk to us and talk to the company people who have supplied and see if there is a pulse pressure variation option in your monitors. And if pulse pressure variation option is there, if they're intubated, if ppb is more than say 12 to 15%, then you know there is a room for giving fluids. Then we measure other advanced indices like LVOT, left ventricular outflow tract velocity time integral, or if you have ultrasound machine, you just put a probe on the IVC and we look at IVC distensibility index or IVC variability index. All these formulas are given at the end of algorithm. I'll talk to it when we come there. So these are the indices to see whether this intubated mechanical ventilated patient has a room for giving fluid. So if these indices suggest to you as per the algorithm that they have room for fluids, then we would suggest you administer fluid allocates. So the simple uh, thing that I would mention to all our district hospital friends is your assessment and responsiveness to the fluid or fluid responsiveness is not only by these indices. We don't say you have to do a PLR, look at delta PLR, and that is the only indication. So we have to combine all the clinical variables, lab variables, and some of these intervention modalities to ascertain if patient is responding to your fluid. What are the things? Suppose if patient is intubated, he's in a typically in a OT, then you can look at improvement in the entitled CO2 also is indication. So this I would say would not be applicable to our COVID. So simple things like you have given fluids and heart rate is coming down. That itself is an indication that patient is responding to your fluid allocates. Or if his hypotensive and blood pressure is improving, that is a clear indication that he is responding to the fluid allocates that you have given. Or if patient has if he's remained oliguria and if he starts pouring in urine after your fluid resuscitation as per the algorithm, then it means that his his fluid responsiveness there and it is helping him. Or you give fluid allocates, repeat ABG after 4 to 6 hours typically, and when he came, if his pH was 7.2, bicarb was say 14, after 4 to 6 hours you see that pH is normalized and bicarbonate is improved, then improvement in acidosis is an indication that is responding to fluid. And clearly, as I mentioned, reduction in lactate, if it's come with, because we have had patients coming to district hospitals where lactate would have been more than 4, and if it has come down to, if the trends are showing that lactate is coming down from 4 to 3 and to 2, then you know he is responding to fluid resuscitation. And even reduction in hematocrit, if they come with a high PCV or hematocrit of more than 50 and you're given fluid resuscitation, if hematocrit is coming down, it's an indication that patient is responsive to fluids. And this hematocrit is typically is what we monitor in a dengue patient. So dengue patients, we don't need any fancy gadgets. We only monitor improvement in the hematocrit with fluid resuscitation. If patient has liver dysfunction and AST ALT is very high at the outset, then you would see whether reducing AST ALT also may be an indication that patient is responding to fluid. And reduction in the bun and peripheries, when they have come with hypotension, it will be cold, and cold peripheries getting warmer also is an indication that patient is responding to fluids. And improvement in the sensorium, if patient is come obtended drowsy, you're given these allocates of fluids and his blood pressure has been normalized, if he's become more conscious, more compass mental, more coherent, it is an indication that your whole fluid resuscitation has helped. And mixed venous saturation, I wouldn't advocate, but if you have a CVC line, you can take a blood gas and look at the SpO2 and see if there is an improvement. So these are all, so what I'm trying to say, you don't really have to always depend on the fancy gadgets. So try to incorporate all these clinical dimensions and some of the lab investigations, see if there are improving trends, and these itself may be indicative that your patient is responding to fluids. Suppose now you have done all these clever things, you have given, this is a sepsis patient, you have given 2 follow-ups of fluid resuscitation, started vasopressors, then you have done a passive leg rising, and you see there is no more room to give any more fluids, then what are the adjunctive measures that you would give? When they are fluid non-responsive, you could start these patients on IV hydrocortisone. So, and this is acceptable at a 200 mg as an infusion over 24 hours. So, the studies have shown that addition of hydrocortisone may help in reducing the need for vasopressors. And second line vasopressor and inotrope is something that you need to keep in mind. As I've already mentioned, if the LV function is normal, which you would have done at the outset, then the recommended additional vasopressor would be vasopressin. So you start noradrenaline and add vasopressin if LV function is normal. If there is a LV dysfunction, because there are reports of COVID-19 patients presenting with myocardial dysfunction. So if there is LV dysfunction, then we would suggest, or the algorithm suggests, adding an inotrope along with noradrenaline. You could consider starting dobutamine or adrenaline as may be deemed appropriate. So after having done this, so this patient you have optimally resuscitated with fluids, you have added this hydrocortisone to optimize his hemodynamic status. So what are the adjunctive therapies that one could consider? So adjunctive therapies you can consider is, you can give injection vitamin C 1.5 grams IV 8th hourly along with thiamine. There is some sort of a evidence, although one could argue there is no conclusive evidence, but there are around 5-6 studies which have shown some benefit. So you could consider adding this. So ulinastatin, we don't have strong evidence for this. Again, there are anecdotal, a lot of studies mainly from Japan and from the Southeast Asia which shows some promise with the use of ulinastatin in reducing the cytokine storm that typically happens in COVID. So as I said, I would put a disclaimer to all this. There is no conclusive evidence, But when you're pushed to the wall, you're losing out on all strategies, and you're not being successful in gaining control over hemodynamics. You could add in as a desperate measure. And extracorporeal cytokine removal is it is like a dialysis where you do extracorporeal. You would have heard of modalities like cytosorb or polymyxin B hemoperfusion. So these are modalities where blood flows through the filter, and and our understanding is these filters help in removal of the cytokines which are creating the cytokine storm. So again, no robust conclusive evidence. These are all anecdotal reports, but when you're pushed to the wall, you could consider doing. And Sepsivac, all my district hospital friends have heard about this. So this is also a trial drug. So you can discuss with your experts and then decide if you are pushed to the wall when you are losing control over his hemodynamics. You could consider these as an adjunct measures. But as I said, there's no conclusive evidence for any of these. And you could consider tocilizumab, which is IL-6 receptor antagonist. The dosage is 8 mg per kg as a single dose, and you can repeat the dose if there is absolutely no improvement or clinically as indicated. So one dose is what is recommended. Second dose if there is no further absolute improvement with the administration. So these are all adjunctive measures, and I would suggest that all these adjunctive therapies you can discuss with your tele experts and take a consensual call. At least for all these four drugs, vitamin C, I would suggest you can start because it is safe, it has no side effects, and it is not cost prohibitive. But all these other four modalities you can discuss with your experts. And for all the sepsis patients, it's very important we take care of all housekeeping measures. When we say housekeeping, so all these patients have to be fed. There is no business for this patient to be fasting. They should be pain free, and all the sepsis patients are at a moderate to high risk of developing venous thromboembolism. They should be on pharmacological thromboprophylaxis, which is enoxaparin 40 mg or dalteparin 5000 units OD. And all these patients should be propped up. No patient should be lying down flat. They should be propped up. And ulcer prophylaxis, if you think they are at a high risk for stress ulcers, and please make sure that you are having good glycemic control. Desirable to keep the glucose less than 180. And if they are not intubated, please encourage them to do incentive spirometry every hour at least for 10 to 20 breaths, because there is a good robust evidence, especially where lungs are affected. Incentive spirometry helps in mitigating the cascading of respiratory support by optimizing the lung function, and helps in sputum clearance. Although it is a simple archaic tool, so I would emphasize, please make them do this. It would help them to optimize lung function better. And please monitor all the organ dysfunction that you would have seen at the outset. It is very important we follow up on the trends, preferably every day, to see if the trends are improving or deteriorating, to look at any other additional interventions that we may have to incorporate to prevent further worsening. And again, monitor and manage complications of sepsis and septic shock. So that is the algorithm that we have circulated to all the district hospitals. If you just adhere and follow this algorithm to the T, we are absolutely convinced that you can save many lives who are very sick, because the sepsis per se carries a mortality of more than 40%, and the more organ dysfunction, the mortality exponentially increases. So please bear that in mind. By following this algorithm, we all together can save many lives. And the notes I have put at the end of the algorithm, as I mentioned, if IVC diameter is less than 1, then you know patient has a low CVP, you can give fluids. If it's more than 2 centimeters, I would suggest do the passive leg raising and ascertain if there is any more room for fluid. And collapsibility index, if you have a ultrasound echo machine, put the probe on the IVC and check for the maximum IVC diameter and look for the minimum diameter. So maximum minus minimum divided by maximum diameter. If it's more than 40%, patient is fluid responsive. For all the details of this, there are multiple videos on my website. So you can visit my website www.drpradeeprangappa.com. All the pictorial representation as to how we should calculate this has been put as a video. So go through them and enlighten yourself with how to do this. If patient is intubated and mechanical ventilated, we do something called IVC variability index, which is maximum IVC diameter minus minimum divided by mean into 100. If it's more than 12%, they are fluid responsive. Or you can do distensibility index, which is maximum IVC minus minimum divided by minimum. If it is more than 18%, you can give fluid allocats. If you are good in doing echo, you can put your probe on the LVOT and look for the velocity time integral. So maximum minus minimum divided by mean. If it is more than 12% in intubated and mechanically ventilated, then you can give fluids. Or if patient is spontaneously breathing, you can do a PLR and check what is the maximum minus minimum and see if they are fluid responsive. So thank you very much. So that's the sepsis protocol. So if you have any doubts or any clarifications, you can contact me anytime and I would be more than happy to clarify. And this presentation is uploaded on the YouTube and on the website. And if you need to have clarity, you can go back and rehear this lecture. So, and again, fast track I have mentioned. So I'm sure all of you know about this fast track. So thank you very much. And you can go through this lecture again if you need more clarity on this. Thank you.